Welcome to the presentation of part 2 of lecture Crystal Deposition Arthritis. Regarding pathogenesis of acute gouty arthritis, although gout is associated with hyperuricemia, the level of uric acid does not itself precipitate gout. Rather, acute changes in the level of uric acid cause gout. Most individuals with hyperuricemia don't have gout, but if high uric acid level go untreated, 90% of patients develop gout within 30 years. Hyperuricemia is found in about 90% of individuals with gout, but it's also found in patients taking diuretics and even in those taking low-dose aspirin. Again, pathogenesis of acute gouty arthritis. With sudden change in serum uric acid level, destabilization of microtophi in synovium persi occur. They rupture, releasing their crystal content. Crystals are engulfed by tissue macrophages and differentiated monocytes, which release pro-inflammatory cytokines like interleukin-1, 6, 8, and tumor necrosis factor alpha. Mast cells participate early in the process and release histamine and other vasoactive mediators that cause vasodilation. Together with the chemotactic effect of cytokines, neutrophils are attracted to the area and interact with endothelial cells lining blood vessels through adhesion molecules on their surfaces. This interaction ends by neutrophil influx into synovium, which augment the inflammatory reaction and release their lysosomal enzymes with more release of inflammatory mediators. The hallmark pathologic finding in acute gouty arthritis is neutrophil synovitis. Clinical stages of gout include asymptomatic hyperuricemia, acute intermittent gout, interval gout, chronic tophaceous gout. Regarding asymptomatic hyperuricemia, it is laboratory diagnosis. The period of asymptomatic hyperuricemia lasts decades. The incidence of gout increases with ages as well as with the degree of hyperuricemia. The vast majority of people with hyperuricemia never develop symptoms associated with uric acid excess. Now, should we treat asymptomatic hyperuricemia? Think to answer the question in face-to-face session. In acute intermittent gout, the attack of gouty arthritis is usually preceded by precipitating factor that result in sudden change in uric acid level, like trauma or long walk, excess alcohol, drugs like thiazide, diuretics. Usually, the acute attack affects male in fourth decade of life. The first metatarsophalangeal joint is the commonest to be affected. Acute monoarticular arthritis is the commonest presentation. Pain becomes maximum within 8 to 12 hours from the onset, usually severe with non-weight bearing, and erythema overlying the affected joint is characteristic. The attack resolves spontaneously within 2 weeks, leaving the affected joint completely free. The 2015 ACR-ULAR classification criteria for diagnosis of gout can be applied. It includes clinical, laboratory, imaging criteria with score for each. A score of 8 or more indicate presence of gout. In addition, patients who have monosodium urate crystals in asymptomatic joint or persa or in atophus are considered to have gout with no additional scoring needed. In general, for diagnosis of gout, clinically, the affected joint appear swollen, hot, red. Cellulitis of soft tissue is common. Laboratory findings include CBC with leukocytosis, ESR and C-reactive protein are elevated, serum uric acid level is elevated, but normouricemic gout can occur? Guess when to answer in face-to-face session. The X-ray finding of the affected joint show soft tissue swelling. The most important diagnostic investigation is synovial fluid aspiration and analysis to prove inflammatory nature, and examination under polarized microscopy to see the needle-shaped monosodium urate crystals with negative pyrefringes in contrast to the rhomboid-shaped crystals with positive pyrefringes. Treatment of acute gout include endomethacin, starting with a dose 50 mg 3 times daily till the attack has almost completely resolved, then 50 mg twice daily until the patient is asymptomatic. The second drug is non-steroidal anti-inflammatory drug, starting with full dose for 2 to 5 days to control the acute attack, then tapering the dose down over approximately 2 weeks, within 2 weeks. The third drug is prednisone or prednisolone, 30 to 60 mg daily with subsequent rapid tapering within 10 to 14 days. Also, treatment of acute gout can include synactin ampoule intramuscular, which can act rapidly, or colchicine in low dose, 1.2 mg at first sign of symptom, followed by 0.6 mg 1 hour later. Interval gout. Interval gout is characterized by asymptomatic periods between acute gout attacks. In most patients, a second attack occurs within 6 months to 2 years. First attacks are infrequent, of short duration, the patient is free in between. During this stage, the patient must be evaluated as regards age, serum urea, creatinine clearance, 24-hour urine excretion of uric acid, and presence of urolysasis. Chronic tophaceous gout is characterized by recurrent episodes of oligoarthritis and polyarticular arthritis with or without joint deformity, gouty tophi, chronic urate nephropathy, or urolysasis, usually occur 10 or more years after acute intermittent gout. Now, what are predictors of chronicity? Think to answer in face-to-face session. This is an image of gouty tophi in 2 and in auricle in patient with chronic tophaceous gout.